Over to you, Pinak.
Good morning, Dr. Gopalan. Thank you very much. Thanks for that wonderful introduction. And so today we're going to talk about some practical tips to acetabular preparation for total hip arthroplasty. It's a fun talk because you always come out of residency and you're wondering, even though you've had plenty of experience, acetabulum can be rather nerve-wracking sometimes when you're first starting out. So I think this is a helpful talk and just try to make it practical for everybody. So no disclosures pertain to this talk. We'll talk about a few different things. Certainly anatomy, can't do surgery without anatomy. So anatomic landmarks, retractor placement, kind of go over the details of the reaming technique. What's our target for a cut position, anatomic safe zones for screw placement, and some atypical cases. So it should cover kind of a good breadth of what you're going to see in bread and butter total hip arthroplasty. So anatomy. So a couple of things, and I think you need to correlate the anatomy, for instance, to the x-ray. We tend to use, for instance, x-ray a little bit more often now, intraoperatively, such as anterior total hips, for instance. So we want to see what we're seeing intraop in our field and kind of correlate with that with the x-ray. So you can see my marker here. So here's a pelvis, and we're looking at it through almost a view that we would see in the OR. So anterior superior iliac spine is right here. You have the anterior inferior iliac spine here. These are important landmarks for retractor placement, understanding where the screws go. When you look at the socket, you have the labrum, which everyone knows the labrum. You got the cartilage. You have the ligamentum teres here, and the transverse acetabular ligament right across the bottom here. So you have the obturator foramen just below. You certainly have to be aware of your obturator artery here. And the rectus attachment over here at the anterior inferior iliac spine. You'll have your greater sciatic notch and lesser sciatic notch down here, your ischium down here, and your pubic ramus anteriorly here. So those are the landmarks you really want to be aware of. I think one important thing is to really understand what exactly is the floor of the acetabulum. So this is the cotyloid fossa here at the base, and it really correlates on the x-ray to this lateral wall, the teardrop here. So this is the floor of the acetabulum here. It's the medial wall right here. And then you have the floor of the acetabulum right here, which is this lateral wall of the teardrop on the x-ray. So here you can see the iliopectineal and ilioischial lines. You have the teardrop right here, the acetabulum here. You have your anterior and posterior rims. But that when we talk about reaming medially to the floor, that's where this is important. We want to get to the to the bottom of this teardrop right here. So just below this then is where your transverse acetabular ligament is, and you can get your retractors into the obturator foramen as well. So that's important to recognize and really understand what that means. The other thing is, in order to get fixation in press fit cups, which many people use nowadays, is the anterior and posterior columns have to be intact. You have to be able to wedge something in between two spots in order to press fit it. So it has to be wedged between point A and point B. And so that's really your anterior and posterior column, which is shown up here, your posterior column, your anterior column. It's also important, yes, you can wedge it, but we'll show later in dysplastic cases, you may be missing some of this dome here. And your weight transfer occurs through the dome. And so you really need to make sure you have an intact dome here as well, or you need to recreate it with augments or different things like that. So important things to remember in anatomy, cotyloid fossa correlates to the teardrop, and you want to know that that is the floor. So you'll take out that pulvinar on the bottom of that as the floor, and two columns you need in order to gain press fit fixation, and then a dome for that support on top of the cup and for weight bearing. So this kind of brings it into retractor placement. So I think retractor placement and screw placement you should really kind of think of similarly. It really has to do with safe zones, right? So if we want to understand the safe zones, we look at the anterior superior iliac spine. We take a line, go right through the middle of the acetabulum or the cup when we're putting screws in. Then we draw a line 90 degrees or perpendicular to that. And we break them up into this posterior superior, posterior inferior, anterior superior, and anterior inferior quadrants. And the posterior superior quadrant is the safe zone. That's the safest spot where we put our screws. There are still risks, and you can see the risks on this side. So superior gluteal vessels and nerve, the sciatic nerve are somewhat at risk, but much further away. In the safe zone posterior superiorly, when you're going posterior inferiorly, the sciatic nerve is also at risk, and inferior gluteal vessels as well. You're aiming more towards the greater and lesser sciatic notches, so that's understandable. So that's why, for instance, in a posterior approach, when you put screws in, you can sometimes put your finger back here, just make sure that screw's not too long or sticking out too far. The iliac vessels are at risk in the anterior superior quadrant. Sometimes in revision cases, you do have to put screws in. You just got to make sure you feel the bone, and certainly they're going to be shorter. The anterior inferior obturator is at risk, and so when you place those retractors, you want to be a little cautious about. But when you take the pulvinar, for instance, out, you always usually see a little bleeder down there, and that's branch off the obturator, and you want to cauterize that. So these are the safe zones for screw placement, and similarly with retractors, you can place retractors in really any of these quadrants. Probably the most common ones tend to be a retractor in the obturator, just below the TAL, just under the rectus, and just below the anterior superior iliac spine, kind of angling it right towards the anterior inferior iliac spine, or sorry, anterior superior iliac spine is kind of a good landmark when you're in the OR to angle it that way. But basically, right under the rectus, anterior inferior iliac spine, you can put a retractor here. You can put retractors all around the rim back here, but just don't want to dive too far in, especially towards the sciatic notches. So sometimes you can use spiked retractors to kind of dig it into the bone here, and that can be helpful. Similarly, you can use spiked retractors into the ischium here, and that can help with your retraction as well. But bottom line, remember, bone's your friend, so you want to make sure you stay on bone. So that's what keeps you safe. So now what do we do? So we got our retractors, we got our exposure. Now we got to remove all the soft tissues. We got to do their soft tissue debris. So here in an anatomic specimen, you can see the labrum, you can see the transverse acetabular ligament, you can see the, although pulvinar is taken out, you can see the bottom and the floor of the acetabulum, or the floor of the cotyloid fossa here. So we remove this labrum, remove the pulvinar, which allows us to see this. We cauterize the obturator branch down here, and then we can start reaming. So what do we actually start to ream at? Well, it depends on what you plan. And so generally speaking, many women are around a 54 cup and many men are around a 56 cup, plus or minus 2 for each one. And in this case, you want to generally start somewhere around 5 to 8 sizes smaller. Everyone's a little different. But when you start with your first reamer, so I'll typically start around a 47, you want to medialize to the floor of the acetabulum. So we were talking about the floor right here. We want to go straight medial. So on a posterior approach, you're almost aiming straight to the floor, or a lateral approach, when the patient's in the lateral position, you're going straight to the floor. On an anterior approach, you're going almost straight across 90 degrees, almost the wall on the other side of the room, or perpendicular to the sagittal axis of the patient. And you want to see some bone inside the reamer. You want to recognize that you have taken some of that bone and cartilage away, and then evaluate it. And when we say, go back there, when we say that we're going to the floor, that means really the superior part right here, right? It's a three-dimensional structure. You're not trying to completely eliminate this entire fossa here, but as you medialize, it's this top part that's going to become more flush. The inferior part isn't necessarily, and that's not what you're looking for. You might end up too medial if you try to make this completely flat. And the other thing you want to see is you'll start to see these excoriations around the rim to see that the reamer is actually actually working. And so you start to see that. Now, you don't have to medialize all the way on the first reamer. You'll have more reamers to go, and you want to give yourself a little leeway so that when you're pushing medially in the other reamers, you're not going to burn a bridge or go too far medial. So when we start off there, the question is, why are we medializing in the first place, right? So, well, basically, there's a few different reasons. One is a lot of times the bone is somewhat sclerotic. And for that reason, some people will actually take out the osteophytes beforehand. You might not see the floor of the acetabulum because there may be a medial osteophyte. There might be osteophytes along the rim or a calcified labrum. And you can certainly remove those ahead of time as well. Sometimes they'll try to kick your reamer one way or the other. If you're aware of them, you can kind of push into them and just recognize they're there. I don't typically remove them right away. I sometimes find it helpful to put at least the first reamer in, and kind of gives you sometimes a better view of the anatomy. But I will typically use the reamers and then take the osteophytes on after. There are two different ways of doing it. You can take them out before or after. But the whole point being is when you medialize, you want to get into that sclerotic bone, so it allows you to then expand and get that good bleeding bed. You may find as you're reaming that you get to the size reamer that you wanted to finish on, and you're thinking about putting the cup in, but then it just doesn't look right. It's not enough bleeding bone. And it's probably because you didn't quite spend enough time medializing a little bit and then expanding. So then you want to go back down some reamers and really try to get into that sclerotic bone. Or your rep didn't get you the freshest reamers and they're just dull. So it can happen. You want to look at those things. You just want me to get into it. Once you get into the sclerotic bone, the other thing it helps is really to get more coverage, right? So let's say you have dysplastic acetabulum, for instance. Medialization is really helpful because once you medialize, you get more coverage superiorly over that dome, because that's where that weight transfer happens. The other reason is just biomechanical, and this is diagram basically explaining, so the different forces are acting on essentially a seesaw or a lever arm, right? So the weight of the patient is down here. It's acting at this fulcrum. The forces of the abductors are acting in this direction, but this is the fulcrum on which they're acting. And if you imagine you leave the leg length and offset completely normal, you leave everything the same in the femur, but you just shift this point medially. Now the abductors have a longer lever arm, so they're more effective. They can put less force in order to enact a certain force across the hip. So if you have a smaller fulcrum, larger arm here, arrow keeps going away. A larger arm here, if you medialize it, you increase the lever arm of the abductors, so you actually put less stress across the hip. So that decreases your joint reactive force. So this gets a little confusing. For instance, you think, okay, I'm putting less force across the hip. Doesn't that mean my hip is less stable? No, and that's where this helps to understand, okay, well, when we talk about leg length and offset, this is more of a static thing. I mean, it has dynamic implications, but if you think of it more and more as a static thing, we're talking about tension in the muscles, right? So the static tension in the muscles is giving that stability to the hip. And that's what happens when we increase offset or increase leg length. We're increasing the tension across the muscles, and that tension helps stabilize the hip. The joint reactive, now certainly that does put more stress across it, but the joint reactive force is different in that means, because we're, like we were saying earlier, even if we keep the leg length and offset the same, if we shift that point medially, now we're just putting less force across the hip joint itself, even though leg length, offset, everything else is the same. So stability wise, everything's the same. It's just that we are putting less stress across the hip, the socket. So in the old days, well, not that long ago, the older polyethylenes used to wear away quicker. So that was important. We didn't want to put as less stress. That's less wear on the polyethylene. It's less stress across the cup itself. So that means it's less likely to loosen. So that's a reason why we want to medialize. The downside is bone loss, right? You're going to take a little bit more bone away. if you have a really young patient, you may not want to metalize all the way. You may want to try to preserve as much bone as you can, just because you expect them to need a revision down the line, but you still need to metalize some. So that's the rationale behind metalization. So now we metalize, now what do we do, right? So we have our reamers in. Now, a couple things to be aware of is, okay, what is the soft tissue doing to you? You want to understand, what is it pushing your reamer one way or the other? So for instance, in a posterior approach, you're gonna be pushing all the tissues anteriorly and retracting them anteriorly, but those same anterior tissues are going to push you posteriorly. So you want to push against them. You want to push anteriorly and inferiorly to make sure that the tissues don't push you into the posterior wall and you start reaming out the posterior wall. Similarly, anteriorly, you're retracting a lot of the tissues posteriorly, and so you don't want the tissues to push you anteriorly and ream out the anterior wall. So you basically want to stay in the center. You don't want the tissues to push you one way or the other. Check the walls, right? So periodically, you can check the walls, you can push on them. They really shouldn't be flexible. If they're starting to feel thin, a little flexible, they're getting a little thin. So make sure you start pushing against those tissues and try to avoid the tissues dictating your surgery. Double check your retractors. A lot of times when you put the reamer in and out, you might catch a retractor, and it's not your assistant's fault. It is just really that, you know, it happens, and you may need to replace your retractor and make sure they're in a good spot. There's a good little rule, you know, especially in weak bone, for instance, you know, older female patients. You put the reamer in for about 3 seconds, stop. That way you don't overdo anything. Do 3-second spurts, so that way you can assess it and see, okay, does this feel okay? Can I go a little further? And just kind of keep going like that. So doing little spurts like that can be helpful. So we want to stay safe. So now we've remedially, what are we going to do? Well, we're going to expand. So what does that mean really, right? So we've created this medial defect. We've essentially made it, and it's no longer not a hemisphere, not that it was in the first place, but now we need to make it into a hemisphere. So you can see on this little diagram, you medialized here, and there's this kind of ledge right here. So now we want to expand this so that we remove that ledge, or remove that superior bone, that dome. And the way we do that is we go up the reamers and we try to expand it into a hemisphere. So usually I'll go up by 2s, and we stay on odd reamers because most of the cup sizes are even, and so we want to under ream by 1. So if I was putting a 54, I'd ream to a 53, evaluate it, see if I like it, and then put a 54 cup in. That gives us a press fit by 1 and gives us a little bit of tolerance in terms of reaming technique, bone quality, things like that, to give us more of a press fit. So when you expand, you also want to now bring the reamer not straight medial. Now you want to put it where you anticipate the cup to be, right? So now you're going to push a little bit medial, but you're also going to push more up superiorly and medially as well. And you're going to drop your hand. You're going to drop your hand to bring it closer to where that cup position is going to be. And we'll talk a little bit more about that part in a little second here. It's helpful here as well I keep my hand close to the tissue, right on the handle, so that I don't plunge. And weak bone, for instance, that's really helpful. And it's kind of like, you know, spine or different surgeries that you're trying to use the patient's body to prevent you from plunging. So, so here, you know, we're just talking about bringing the reamer to the position that we want it to. So how do we know what position we want, right? So there are a few different things. Generally, you know, we talk about Lunax safe zone. So about 40 degrees abduction, 20 degrees anteversion. That's a simple, easy way to remember that. We'll talk a little bit more about that and its relevance now. But what you want to look at, the anatomic checks while you're reaming to know that you're in a good position. So there are checks for anteversion. One thing that I'll do is, this is where that rectus attachment anterior inferior iliac spine is, kind of put your finger right around this 2 o'clock position. If this is the 12 o'clock, this is about that 2 o'clock position. It's pretty much right where your finger will fit, honestly. And then that should be about flush. The reamer should be about flush with the rim here. Now, if you have some osteophyte here, you may want to take that into account and maybe take that out beforehand. If it comes out easily, it's ossified. If it doesn't, it's probably part of the wall. So then it should be about flusher. That should give you about your correct anteversion. And keep in mind your psoas comes out there as well. And so if it's flusher, you're gonna avoid that psoas impingement or psoas tendonitis. The other way to check is look at your transverse acetabular ligament. And with the reamer in place, you can actually see that fairly well and you can feel it. When you put the cup in as you're putting it in, because it's not seated all the way, it kind of blocks your view. Sometimes it's helpful to just draw a line on the patient. And you want to be perpendicular to this, right? So you don't, if my reamer is coming in like this, then it's not really perpendicular. I want that reamer coming in perpendicular like that handle, perpendicular to TAL. Those are checks to kind of match the anatomy. And you expect, as you get closer to the expected size, that a little bit of that reamer is going to stick out. A little bit of that cup's going to stick out posteriorly, and that's normal. So checks for abduction, look at where that reamer handle is. So relative to the floor, if the patient's in lateral position, relative to the floor, really the pelvis, the sagittal plane of the patient, it should be about 45 degrees, right? And that's going to give you, and then you can drop that down a little bit, 5 degrees roughly. The other thing is you can look just inside the TAL. So if you're abducted appropriately, you'll see just a little bit of that TAL just outside the cup. So your cup will sit just inside the TAL. On the x-ray, like we were talking about, the inferior cup is usually going to sit right at the bottom of the teardrop. And so that can be a helpful landmark to show what that looks like. Actually, I think I have, so if you look at this, for instance, you can see this inferior bottom part of the cup is right about that teardrop level. And even if you had to ream superiorly, for instance, if you're doing a high ebb center or dysplastic cup or something, if you draw a line across here, across that ellipse of the cup face, it'll essentially usually be about collinear with the bottom of the teardrop. And so it gives you, or at least kind of a parallel plane. So that kind of gives me a good guide, for instance, on anterior hips, is to quickly know what my version is what my abduction angle is. So those are some good landmarks for abduction and inversion. Those are anatomic landmarks. I've found them really helpful over my last 8 years in practice. They've been, very, very, I think, in a sense, patient specific. So I think they've worked really well. You can also ream under x-ray, right? Ream under x-ray, see if you like it. If you don't like it, adjust it. If you're not sure where you are, take an x-ray. You can put the guide on the reamer as well. There's some guides that we'll talk about here in a little bit. So we've expanded, we've put our reamer into that position that we want it to be in. And a couple other things you want to be aware of. Don't hurt yourself, right? So in sclerotic bone, it's going to catch. So you might twist your wrist, you might injure your wrist or elbow. So you want to be careful with that. So a couple things you can do is put your body or torso at first in between the reamer handle and the patient body, so you can use your body to prevent that torque. And start the reamer a little off bone. Don't start it right next to that sclerotic bone, and it'll catch and it'll twist your wrist. So just be careful, protect yourself, be cognizant of that. Ergonomics are important, especially when you're doing joint replacements. As one of my partners used to say in Nebraska, that it's a marathon, not a sprint. So these are just some helpful things there just to keep you safe. So now that we've expanded, right, how do we know when we're done, right? What point are we finished? So there's a few different things you want to look for. So we've medialized, we expanded. We want the bone to grow into the implant. So how does the bone grow into it? We need some bleeding bone, right? So generally you want about 80% of the bone that you see to be have some punctate bleeding. What does that really mean, right? So everyone says that, but what does that really mean? So sclerotic bone doesn't bleed, right? Where are the blood vessels? The blood vessels on the subchondral bone and below, right? So if you don't see bleeding bone, then it's still sclerotic bone. If you start to see some punctate bleeding, then that is the subchondral bone. I usually will wait, you can suction it out, you can put a lap in, dry it up, pull it out. You wait a couple seconds, it's a good thing about 3 seconds in a lot of things. Threes, rules of threes for a lot of sports, everything. You see some bleeding bone, that you should be fine. Now, just because the bone is hard, right? You're not looking for cancellous bone. Just because the bone is hard doesn't mean that it's sclerotic, right? So the subchondral bone is a strong plate of bone, and but so it is still hard, but it's not the sclerotic bone. Once you're past the sclerotic bone, you'll see that bleeding subchondral bone. It's still a very supportive bone. Now you can go a little further down. You can get into deeper layers of subchondral bone, and if you really need more coverage, you get into more of the cancellous bone. But the most important thing is that you're in a good bleeding bed and supportive bone. So that's what you want to look for. You want to look for that 80% about punctate bleeding. You dry it up, wait about 3 seconds, it's bleeding. You'll recognize that. Recognize that sclerotic bone will not bleed, subchondral bone will. And so that's how you know that you're in the right spot. You only need about 40, depending on the study, so about 40-50% of that to really grow in. And these things are pretty forgiving, right? So the ingrowth surfaces on the cups are really advanced now, and I think they're very forgiving. So but you want to get as much contact with the bone as possible, and as much bleeding bone in contact with a cup as possible. So if you really had to, I mean, the most important area, yes, is at the dome. That's where the weight bearing is. That's where you want it to ingrow. So that's a very critical area to make sure you're bleeding. And that's why when we're expanding after we medialize, that's a really good area to check. Check the dome, make sure that the dome has that bleeding bed, that posterior superior area where you're going to put those screws. What I like to do when I get close to the reamer is also put the reamer in and kind of move it a little bit. It should grab. It should, a lot of times, maybe not all the time, but a lot of times it'll kind of grab. It'll almost feel like a trial. I don't typically trial, but I use essentially the reamer, the last reamer, the expected reamer, to feel like about a trial. And if it grabs a little bit, it tells me that I'm getting close to that point. And then I should get a good press fit on the actual reamer, or on the actual cup. So how far do you ream? As we talked a little bit earlier, you can ream, under ream by 1 or line to line. A lot of people under ream by 1. You can, in weaker bone, ream line to line, because you expect the bone to be more viscoelastic. It's going to expand a little bit. And so you want to be able to have that press fit. And so if the bone's really weak, you need to accommodate for that. Most of the time, though, under ream by 1 works very well. It accounts for any asymmetry in reaming technique. It accounts for the weaker bone, and gives you a really good press fit. In revision settings, that can be different. In a more revision type cup, sometimes you may need to ream line to line, or if it's not quite getting down, you may need to touch it with that. Say if you're putting a 54 cup, you need to touch it with the 54 reamer. So now that we're done, you may need to fine tune it. What if you don't like it, right? So these are some helpful kind of concepts. So I kind of made up, but they're, you want to avoid creating an egg, right? So if you think about an egg, it's not hemispherical, right? You're creating a deeper point in the socket. You're over medializing. So if you over medialize, you've created this apex in the socket, and you don't want to do that, right? So how do you avoid doing that? Well, it goes back to the expanding, right? So you're expanding that into hemisphere. So if that's the apex, now you need to expand that. So you have the reamer head in here, and you want to rotate it like this to really expand the rim of the socket to get it more hemispherical, and then go up a size reamer until it fits symmetrically. So that's where I have this top here. I think of it as kind of spinning a top around the tip, around that reamer axis, to try and get that rim, expand that rim, and then get that hemispherical cut. So the other way, another technique of doing that, kind of combined with it, is if I'm going to exaggerate here, but the rim is tight here and you really deepen this here, you want to expand this introitus, or the entry point of that. So the way you do that is you can just go in a little bit and kind of out a little bit to expand the introitus, or expand that opening of the acetabulum. So those are 2 different techniques to try and make that hemisphere. The other part is sometimes that rim up top is really sclerotic. That superior dome is really sclerotic, and it looks flatter. and you'll see that it looks a little flatter, or maybe your cup's not sitting down all the way. And if the cup's not sitting down all the way, that's something you want to look for. Both of these things. So if it's more of a flat top, a flatter dome, you want to ream up and in. So you want to take that, go back to the reamer, take that reamer and go up and in, push superiorly and go medially, kind of towards, not straight medially, right? You're going to push up towards the dome basically to get that in there, in the position you expect your cup to be. The other part is maybe you don't like it, you don't have enough bleeding bone. And this happens from time to time. If you don't like it, just go downsize, start over. It's frustrating, but you can get into that bleeding bone and get a better bed for bony ingrowth. So make it a hemisphere. If it doesn't look like it, ream where it doesn't look like a hemisphere. So then you trial. Like I said, I don't trial. I use a reamer as trial. And then you want to implant, right? So irrigate it, check your bone, make sure there's no bony debris, no leftover pulvinar or labrum, anything that you might have even fall in, or sometimes you'll notice a little bit of labrum or something that you missed, or a little bit of pulvinar, maybe the TAL is starting to get in the way. You can thin out the TAL. You can take a little rim of that TAL. You don't need to take the whole thing, but take a little bit of it out. So then you impact the cut, and you want to place your screws posterior superiorly, right? So that's where you want them to be. And if I go back to here, I like to think of where those screws go. I tend to put, if you draw an ASIS, to draw that line straight to the middle, my anterior screw I'll usually have right abutting that line. And that gives me some options if I need to put additional screws across the posterior superior quadrant. So I think that's a helpful landmark there. So, and then you want to check if you're down, right? So you can check on the x-ray, see if you're down, place a Schnitt or Freer, something in the holes and screw holes to make sure that the cup is actually seated down to the bone, and make sure you got that press fit. So I like to shake the pelvis a little bit. So the socket, if you have great press fit, it should move that pelvis without any motion of the cup itself. And be careful. Sometimes if the handle loosens, you might notice the handle loosens, and be aware of that. Just tighten the handle and just make sure that that cup is moving the pelvis. So if you're not getting good press fit, what do? Well, remove the implant, check for any interposition bone, soft tissue, what have you. And like we talked about previously, is it not fitting because it's getting tight on the rim, meaning it's not spherical? Or is it just that maybe it's a little loose? Maybe the bone expanded a little bit too much as you put it in because it was too weak? Or maybe the reaming technique, it was a little looser and you didn't quite get that press fit because there's you essentially reamed a little wider than what the press fit would allow. So if that's the case, then there are two different techniques, right? So if it's aspherical, just ream the introitus like we talked about. Go ahead and do the spinning top to try and ream the perimeter of the socket and expand that so that you can get it more spherical. If it's just a little bit off, sometimes just touching that last reamer a little bit can be helpful. And if it's loose, you may just need to upsize it. You may just need to accept that, hey, I may have reamed a little bit too much, and maybe I just need to upsize it. Sometimes the other option is to take a revision cut, which is a little thicker ingrowth surface on the back, and so that can be another bailout option. In that case, it has more press fit, and so it makes up for that. So a few different things that you can do if it's not quite the press fit, but you want to make sure you work to that. So a few other helpful tools for a posterior approach or anterolateral approach. You can use this when the patient's in the lateral position. You can still use an anterior approach too, but this guide attaches to your impactor or your reamer, and the A component you want to be perpendicular. For instance, when the patient's in the lateral position, you want it perpendicular to the floor, and that should give you your 40 degrees of abduction, right? So you can dial it down 45, and you can dial it down just a little bit to get that 40. The A are these cross hairs over here, the B. One is for left and one is for right, so make sure you're looking at the correct one, but you want that parallel to the back of the patient, so the axis of the patient. If the patient has some spinal deformity and they're flexed forward, be aware of that. Then you may not want that. Those are a good rough guide as well, in combination with the other anatomic landmarks we were discussing. So that's helpful. And of course, there's robotics, computer assisted, different technologies that various companies have, and are all fantastic, and really help you in being as accurate as possible. So that can be very helpful. You know, they're all great tools. They'll give you visual cues about exactly where you are. So those are all different techniques. And so a few other things is, well, we always talk about the 40-20. So Lunax safe zones, you know, these are safe zones that have been around for quite some time. They're very helpful, I think, as a really general guide, but they're really not as accurate, or they're not as predictive of instability as I think we gave credence to previously. And I think that's been well studied, various studies. This is an example of one study. This is a study at Mayo Clinic, 9,784 patients. And these are fellowship trained joint surgeons. Of these cases, they had 2% dislocate. There are 206 dislocations. There are different approaches. But if you look at the scatter plot on the right side, you can see in the box is the ones that are in the safe zone. The posterior approaches are the blue circles, and the anterolateral approaches are the red X's. All of these are in the box are in the Lunax safe zone, but they still dislocated, right? So that's 58%, I think, of all of, 58% of all of them. I didn't write that on there, but 58% of all of them in this study were in the safe zone. So these are all the hips that dislocated. 58% of those were in the safe zone for the socket. So of the posterior approaches, 65% were in the safe zone. Of the anterolateral approaches, 33% were in the safe zone. But the odds for dislocation were significantly higher for a posterior approach than an anterior lateral approach, even though 65% of the posterior approaches were in the safe zone. So I think while it's a helpful guide, it certainly doesn't tell us the whole picture. There's so many things that affect stability, and I think I think in general society tends to oversimplify things. And while it can be helpful, it's not just one single thing. And so, there's a lot of things: spine deformity, pelvic tilt, the tissues can be a little lax, the patient's range of motion might be more, they might have avascular necrosis, and those patients have a little higher risk, for instance, of dislocation. The patient's just, activities may be the type that are more apt to dislocate. Maybe they're just in more compromising positions. Certain patients may not follow restrictions. I think it's, a posterior approach, when we do those approaches, the position in which it dislocates is oftentimes more often a functional position. And so, whereas anterior approaches tend not to dislocate in more functional positions. So I think that might be part of that, not advocating one or the other, but I think a well done total hip is a good total hip regardless. But their point being is there's so many other reasons why I think patients dislocate. And then that's why I really trust the anatomy more than anything else. I'm going to put it where the anatomy says, and that's been good for me. Also the femoral component position, you may have some femoral dysplasia, may force you into some anaversion or so on and so forth. There may be some impingement or, leg length offset issues. None of those are typically discussed in a lot of these studies. Patient comorbidities, any neurologic disorder certainly increases your risk of dislocation. So there's quite a few different things that may contribute more than just cup position, but it's still, I think, a really helpful overall guide of where you want to put the cup in combination with the anatomic landmarks. So I think with robotics and navigation, that's where I think you got to be careful with that. Is it targets the numbers, I think, more so, which is fine. But we don't really know what the target really should be for every patient. And so that's a little challenging. There's some three-dimensional things that different companies have in terms of understanding predictive impingement. But of course, that doesn't take into account the soft tissues. You can take a CT scan and evaluate, okay, if I put the cups here, so on and so forth, where is it going to impinge? But, a patient may have a bigger thigh. And I think, for instance, these big patients sometimes can impinge on their own thighs. So there's different factors that come into play. So, but we still want to get the cup as a good position as possible. So just to finish off with a few different kind of unusual cases, or, things that how to deal with. So protrusio. So there's a difference between coccygeal profunda, protrusio, acetabuli. The floor of the acetabulum is medial to the ilioischial line, Kohler's line right here. And if the head proceeds medial to that as well, then that is protrusio. So in this case, you really don't need to medialize, right? Because it's already so medial. So it's a different, you have to think about it a little differently. So you still want a good bed of bleeding bone. In this case, there's a few different ways you can manage it. We were talking about the reaming the rim essentially. So this is where we talked about, for instance, a rim fit could be an option where you don't want to ream too far medially. You put your hand close to the patient right on that reamer handle so you don't plunge medially. You still want to get as much bleeding bone throughout that whole surface as possible, but now you're dealing with some offset issues that you may need to reconstruct. So if you have a good bed medially without going through, and frankly, even if you go through, most of the time it's a contained defect and it's going to be fine. So, you know, as long as you have some bleeding bed there, if you really want to lateralize the hip again or lateralize the socket, there's a couple different ways. You can put some bone graft there, ream it on reverse so that it doesn't take away bone, but compresses that down, and then put your cup in, if essentially getting a rim fit, and put your screws in. The other option is a lateralized liner. You can put your cup in and then put a lateralized liner as well. So a few different options of dealing with that, but the same fundamentals. It's just that you don't need to medialize to the same degree. You need to primarily focus on expanding and getting a good bleeding bed, and then deciding how you're going to regain your offset, whether you're going to use a lateralized cup, a lateralized liner, you're going to put some bone graft, reverse ream, and then put a cup and then put the screws in. But a few different options. All of them are reasonable techniques, and certainly depend on the situation. So like hip dysplasia, both of these are just talks in themselves, but Crow classification shown at the top: 25, less than 25, 25, 50, 75, and 100%. Translation of the femoral head. So this is some example. Dysplasia can be of the acetabulum and the femur, and one or the other, or both, and oftentimes they're associated with some significant deformities that you have to consider, and it's helpful to have some different options. So the socket, the acetabulum, whereas a lot of times, in typical osteoarthritis, you're going to see more posterolateral wear, you're going to see more anterolateral wear and acetabular deficiency on a dysplastic case, and they may have some abnormal anaversion. As opposed to like a pincer hip, you may have some more retroversion. The femur is also going to have more dysplastic characteristics, more anaversion, little posterior greater trochanter, valgus neck, hypoplastic canal, all these things listed down there. So with this, different techniques are available to us, but this goes back to, we talked about having two columns to press fit the cup into, and you need that dome, you need that superior bony support. So that second part of it is where this comes into play, is you need to create that bony support. So even though you can get a press fit on the cup, now you really need to get that superior dome support, or this is just going to toggle and it's going to loosen. So there's some different ways of doing that. A classic way of doing that is to take the femoral head and kind of bolt it onto the cup, which is shown in the center here. You can bolt it onto the socket here and essentially use that femoral head as bone graft to recreate the dome. In similar fashion, you can use augments, which are metal augments that do exactly the same thing. The downside is both of these may not incorporate or may resorb, the bone graft here, or will loosen over time, and sometimes aren't as reliable. So they're great options, but there are some other options as well. A couple of the other options, for instance, are a higher hip center. You can accept it. All their tissues have been shortened for a longer time. You don't have to deal with doing a femoral osteotomy to shorten that up. The soft tissue tension is appropriate. Now, leg length is certainly still going to be an issue, but a high hip center is certainly a viable option. The other thing is a jumbo cup, which you can do that to a certain degree, and it's a helpful tool to have. And some cups in different companies have some, it's not quite a double bubble cup, but have a superior extension, essentially built-in augment. And this just allows you to expand. And personally, I try to use a jumbo cup when possible, just because the cups are so reliable nowadays. And if you can get a good solid large cup in, I think it tends to last longer and do better. So there's some examples of different cases that you can do. But yeah, I think it's just to summarize everything. I mean, I think it's very important to recognize the anatomy here. Always be aware where you are, where your retractors are being placed. Understand where that cotyloid fossa means and what we're talking about when we medialize. Why do we medialize? In order to decrease the joint reactive forces and put less stress on the cup. Hopefully let the cup last longer. The poly isn't so much the issue anymore. And understand that after you medialize, you're really trying to expand that cup and allow it to create a hemisphere. And understand that you're going to you want to create a good bleeding bone, and wait 3 seconds, see about that punctate bleeding. You want about 80% of it bleeding. You want to get as much contact as possible. Just because it's hard doesn't mean that's a sclerotic bone. But it's okay to get in deeper, but primarily focus on that punctate bleeding. That's how you know you're in the subchondral bone. Use that reamer to give you a judge of if you're in that bone, if that's the correct size. See if it gets you that bite or moves the pelvis a little bit. It may not be perfect, but it'll give you a sense if it catches. If it's asymmetric, fix it. So if it's too deep, ream the introitus, make it wider. Don't go medial, just expand it. Spin it around like that top. Avoid that flat top. So if you got to go up and in. So just like this diagram, don't go medial here like you're angling this way. You're angling this way, up and in. That's how we ream the flat top or the dome if it's sclerotic here, to recreate that and get rid of that sclerotic bone so you can prevent it from seating your cup all the way, or prevent it from blocking your cup from seating all the way. Protect yourself, of course. Make sure to protect yourself. Don't forget, you can get lost in the surgery sometimes and forget about taking care of yourself too. Use all your anatomic landmarks for cup positioning. Feel the rim, feel the anterior inferior iliac, or you may not really feel the anterior inferior iliac spine, but you can feel the rectus about that 2 o'clock position on that right hip. That should be about flush. So then your anteversion is about appropriate. Use that transverse acetabular ligament. Use the X-ray. And use the guide as well, and all that will be really helpful. Just recognize that these are good guides, but I think anatomy is really your best bet. Yeah, that's pretty much it. So, any questions at all?
Thank you, Pinak, for that brilliant talk.
Sure, absolutely.
A lot of people are watching the talk, and because it's full of really practical, useful tips. And I like the way you presented at the end that you did a quick review of what you spoke, because that's also going to be very important.
Yeah, that's I'm glad. I try to make it as practical. I mean, try to think about what things as a resident confused me, or I didn't quite get until I got into practice, I think, or you hear it but you never quite get it.
A couple of questions. Now, when we talk about screw placement, most of the screw placement is superior, right? So are there situations where you have relied into an ischial screws, something called as a kickstand screws, especially if you've not had enough of contact between your cup and the acetabulum, if there are defects?
Yeah, absolutely. So if I go back to that slide, most of the time it's in revision cases. So if you're doing a revision cup here and you want to get as many screws, you want to check your press fit. So if you have a decent press fit, you may not need as many screws. If you have okay press fit, you may want a little bit more screws. So one thing, like you're talking about, the kickstand screw is very helpful, is to get superior and inferior fixation. So judging where those screw holes are, in those cases, I'll kind of mark the ischium down here and just kind of make sure I can see that, so I can see where that screw hole is, so I can place it there. Make sure I have, in those cases, certainly it's a multi-hole cup. And so I'll try to put my screws superiorly and make sure I can line something up inferiorly. It doesn't always work, you know, to get it straight down the pike. When it does, it's beautiful, but you know, the idea behind that is you don't want to hang your cup on the dome, right? Because you want your ingrowth on the dome for sure, but if you hang it on the dome, that means you don't get as much fixation down inferiorly, and a lot of times that's where you're missing some bone. And so if you're missing that bone in revision cases and your best bone is up superiorly, if that's your only fixation, then it is essentially hanging and it can toggle and it has a higher risk of loosening. So in that case, it's helpful to line up your screw holes into the ischium and get an ischial screw, whatever you can, down the pike. And you can even do that to the symphysis, to the superior ramus as well. It's just you have a little more bone to work with on the ischium to try and get some of the ischial screws. And you can also try to get posterior screws as well. And you're going to try really all the quadrants, wherever you can get the screw, being careful with your drill. But that's helpful because then there's less risk of it toggling. You can get some inferior ingrowth. But yeah, that's a really helpful thing in revision cases, for sure.
Thank you, Pinak, for that. And what about the use of hydrogen peroxide to the, to the floor so that you get a completely dry bone? Suppose you're doing a cemented hip replacement. Are you a cemented or uncemented guy?
So I use uncemented. There are rare cases where I will cement something, but I mean, usually that's like in an, you know, on a two-stage revision or something. I'll cement in a poly or something like that, but usually not a cemented cup. I don't have any experience with peroxide to cement. That being, most of my experience is more in press fit. But you know, I can understand that would make sense. You know, certainly to get rid of as much bone as or blood as possible, keep the bone dry. You know, I will cement a stem every now and then, but usually that's more on hemis if I need to. Still tend to press fit that a little bit more often, but yeah, I don't have any experience with peroxide, but I think that would certainly make sense. You know, you just want to keep that bone as dry as possible. And I'll, you know, use the last sponges to really irrigate, make sure the blood pressure is low, you know, or, you know, low enough to make sure it maps 70 or less. And yeah, you just want to make sure it's as dry as possible. Make sure that keep it dry, you know, keep that sponge in there, keep that suction in there. I would, before, you know, just before you're ready to cement, and then just make sure that you can get that cementing right away. But yeah, I certainly don't have very much experience cementing cups in for total hips. But interestingly enough, the longest total hip I've ever seen that I revised was in for about 43 years, and it was a cemented cup, and it was vertical, right? So it was incredible, right? And so of course I ended up revising it, and sure, it did end up loosening and the femur was loose. But yeah, I mean, 43 years for a cemented cup that was vertical just goes to show you how little we probably really know sometimes.
Thank you, Pinak, for that. And you've shown an image of an intraoperative image intensifier. Do you always use a image intensifier for your acetabular?
I probably do probably 95% of the cases anteriorly. So I'll usually will have an image intensifier. If for some reason body habitus, or they have more of a champagne flute pelvis, you know, really decreased offset, and I think I might, or really a fleshing retraction of the hip, you know, more than about 10-15 degrees, then I will go anterolateral. So then I'll typically go, you know, a mini modified Harding approach. So in that case, I typically don't use the X-ray. It's a little harder to get a good quality X-ray in that position, but I will use it when I'm going anteriorly. So I do find that helpful, but to be honest with you, I tend to trust my anatomic landmarks and use the X-ray as a verification step, because there are still so many aspects to the C-arm to make a perfect X-ray, whether it's leg lengths or cup position, that, you know, sometimes I'll find myself, if I adjust something on the X-ray, I'm like, I'm not convinced, and then I realize, you know, maybe that wasn't the right move. And so I trust the anatomy more than anything else. I just use X-ray as a double checker tool. So
Thank you, Pinak, for that. Just one last question before we wind up the session. Now, you've shown a picture of a dysplastic scenario where you've used, a jumbo cup as well. So how do you decide whether you're going to accept a high hip center or a normal anatomical hip center? What is the crucial process by which you make that particular decision?
So I think the Crow 1 and 2, it's very easy to do a jumbo cup. I think as you get to Crow 3, I think that's where I am, I'm more willing to accept a more higher hip center. I think Crow 4, 3 to 4 is where I really start debating what the best solution is. I think in those cases, the jumbo cup is, you end up having to go so big and you have to utilize so far to get enough coverage that I think in those cases it's helpful to preserve bone and try to either keep a higher hip center or try to use an augment, and if you need to, an osteotomy. But the osteotomies aren't benign either, right? You're asking them to heal these osteotomies as well. It's a little more certainly a little more technical, and it's not that you can't do it, but you're essentially using the osteotomy to take that tension back off the tissues as well. And so I think it's helpful to use a little more higher hip center and a 3 or 4 if you really had to, as opposed to jumbo cup. But 1 and 2, I think a jumbo cup is a good solution. I think patients still recover, and there's plenty of data out there that high hip centers still recover very well after these Crow 3, 4 dysplastic cases. And so I think that has worked pretty well for me. I don't think that, I think the amount of bone loss that you end up having in a Crow 3 or 4 sometimes doesn't work so well with the jumbo cup though. So, and I think in that case, the higher hip center helps.
And if you look at both these x-rays, do you think there's a difference between the longevity of the implant? For example, you have a jumbo cup on the right side and you have a normal hip, a relatively normal size acetabulum. And so do you think the longevity really affects?
I think from comparing these two, I think the longevity is fairly similar, at least in my experience. But in terms of acetabular augments, those tend to toggle and tend to loosen up in about 3 years or so. And so those augments, I don't trust as much. They're really fun to put in. They're really neat. They're great tools to have when you're trying to reconstruct something you can't find where you're going to get that coverage. But they're just, you're trying to cement in between the implants. There's not really, other than that, there's not really true contact. So the support is there. You're relying on that ingrowth on, essentially you're hanging the augment up, you're compressing with those compression screws. A lot of times the bone's weaker too. And so I think they tend to toggle a little bit more, and for that reason, I think that they are not, they tend to loosen more. Whereas in these cases, you're getting more of full bony contact with a unitized construct, and the other ones, you're trying to unitize it with cement. And I think this is just more effective as one jumbo cup or a higher hip center.
Thank you. Yeah, thank you, Pinak. I think that's all the questions that we have for the session. Fantastic lecture, and I'm sure this lecture is going to benefit a lot of people all over the world.
Thank you. Happy to be able to do that today. Thank you.
Thank you so much for joining in.
It was helpful.